there have been recently very interesting studies published with the so-called second-generation proteasome inhibitors. So the first studies I will briefly discuss with you are the studies with Carfilzomib. So we have two important studies, a head-to-head comparison of Carfilzomib plus dexamethasone with Bortezomib plus dexamethasone, which is called the ENDEAVOUR study. In that study, patients were included that received 1 to 3 previous lines of treatment. Now, the dose of Carfilzomib in that study was escalated to 56 milligrams per square meter, and Carfilzomib was given on days 1, 2, 8, 9, 15, 16 in a 28-day cycle. The most important conclusions from that study were that, first of all, the progression-free survival doubled in the KD arm compared to the VD arm. More precisely, 18 months versus 9 months. Second important conclusion was that in terms of anti-myeloma activity expressed as the level of response and the depth of response, the KD combination get an overall response rate of 77% compared to 63% in the VD arm. And also the high quality responses, VGPR or CR, were double as high in the KD arm compared to the VD arm. Third important conclusion in terms of tolerability was that where we know that peripheral neuropathy is one of the major side effects of Bortezomib, that in the VD arm, 32% of the patients had grade 2 peripheral neuropathy or higher. This was only 6% in the KD arm. Although in the KD arm there were some new side effects. Some patients had some cardiovascular toxicities, which was arterial hypertension, and in a small subset of patients there was cardiac failure. We should not overinterpret these results, but it's a warning signal, especially in vulnerable patients or patients with pre-existing cardiac disease. The second study I briefly want to discuss with you is where we add on additional drugs to Carfilzomib like IMiDs. So it's a comparison of RD with RD plus Carfilzomib, the so-called ASPIRE study. And the major conclusions from that study, where Carfilzomib was given at a dose of 27 milligrams per square meter, were that KRD was significantly more effective compared to RD in terms of progression-free survival. This was respectively 26 months in the KRD arm and 17 months in the RD arm. KRD also gave significantly higher response rates and an unprecedented CR rate of 31%. In terms of overall tolerability, so again, KRD was not associated with neuropathy, but there was a small subset of patients that developed some hypertension or some ischemic heart disease. Importantly, the KRD regimen was more effective if it was given at first relapse compared to second or third relapse. And finally, there is very recently a study published that compared RD plus placebo with RD plus ixazumib. So just to remind you, ixazumib being a boronic acid derivative, but a proteasome inhibitor that can be given orally. And in that study, the ixazumib was given on days 1, 8, and 15 in a 28-day cycle. The primary endpoint of that study was also progression-free survival, and this was 20 months in the ixazumib arm compared to 14 months in the RD arm, with an hazard ratio of 0.74. In terms of subgroup analysis, it seemed that just like with KRD, the IXA-RD was superior among the different subgroups in terms of patient characteristics and disease characteristics. And maybe the most strikingly was that ixazumib was also very effective in patients with high-risk cytogenetics, defined as patients with, for instance, deletion 17p or translocation 414. So that combination maybe could abrogate the negative impact of those abnormalities in relapsed patients. Finally, in terms of tolerability, the ixazumib combination had some increase in thrombocytopenia and mild to moderate skin rash, but there was no sign of increased cardiovascular toxicity. So to summarize, proteasome inhibitors have become an important and indispensable backbone of myeloma treatment, both in frontline and at relapse. Whereas bortezomib, the first-in-class proteasome inhibitor, has really paved the path towards the whole setting of myeloma treatment, it has now more moved to upfront treatment. And the second generation proteasome inhibitors, they are now used in relapse or will be used in the near future, and they will be hooked up to the lenalidomide dexamethasone backbone. These are all very effective treatments that help us to prolong the life of patients with multiple myeloma. But very importantly, these combinations, if they are used the right way, they are very well tolerated. And so this prolongation of the life of myeloma patients should not come at the expense of increased toxicity. So they allow us to treat patients while maintaining also good quality of life.